Hello, everyone. I hope you all are fine and doing well. So, today we'll be discussing about the neurology system, and eventually, you need to remember that neurology is not important for your AMC examination. Whatever the important topics are there, which are frequently asked in your exam, I will be discussing only that. This will be more of an exam oriented session for the neurology. You don't need to remember each and everything about the neurology because neurology is again not important for the MCQ examination. Hardly you will get nearly about one or two questions from the neurology part. Rest of the questions will be scattered among the other systems. So if you have to skip one chapter from your uh, medicine and surgery part, you can skip this neurology. Okay, so neuromedicine and neurosurgery is not important for the AMC examination, but yeah, there are some topics which are frequently asked. If you don't have time, then you can skip this. If if you want to score even the neurology questions also in your exam, then yeah, you need to do only few topics. Okay, you don't have to do each and everything, each and every point, each and every topic. So yeah, let's begin with our first important topic, and that is none other than your spinal stenosis. To be honest, I usually discuss it in orthopedics, but there were some people who were requesting me to just discuss about the back pain, more importantly, the spinal stenosis. So I had to do this, right? I had to do this. So let me tell you one thing is that if you can see it over here, I have already created a very well beautiful diagram of the vertebra, right? You can see over here, if this is the vertebra, okay, this is the nucleus pulposus, right? Nucleus pulposus, which is important here, collagen 1 probably, okay? So which is made up of collagen 1, and then if you can see here, uh, this one, okay, this part, this is what we call as spinal canal. Through the spinal canal there is this passage of our one and only spinal cord, right? One and only spinal cord. More importantly, this would be just like this. Okay, if this is the vertebrae, this is the spine, right? This is again the vertebrae, this is the spine, right? And here we have this spinal canals, and through this spinal cord passes through it, right? Due to any reason, due to any reason, if there is this spinal canal stenosis, it narrows down due to any reason. If it narrows down, that is what we call as spinal canal stenosis, and it will result in the impingement of the spinal cord, right? More importantly, the nerves which are related with that particular vertebral level, right? Resulting in different sign symptoms, right? So as you can see it over here, there is spinal canal stenosis. More importantly, there is central stenosis, which is shown over here. Then here you can see here there is foraminal stenosis over here. But in case of spinal canal stenosis, there is this part. Okay, if this is the spinal cord, if this is the spinal canal, okay, this narrows down. Okay, this narrows down, and resulting in the impingement of the nerves and different sign symptoms. What is the classical sign symptom of a patient who is having spinal canal stenosis? What is the classical sign symptom? Remember that the patient will tell you that, doctor, the pain, remember this please, the pain increases by standing, the pain increases by standing erect Okay, whenever he is telling you that whenever I stand erect, okay, the pain is increased in my back. Okay, there is a severe kind of back pain whenever I try to stand erect, or whenever I move a downhill. Okay, while moving downhill, the back pain exaggerates, it increases. Okay, it increases. That's true. Again, very important point. Remember that the spinal canal stenosis, whenever I talk about the spinal canal stenosis, okay, whenever I talk about the spinal canal stenosis, always remember that this is also called as neurogenic, neurogenic back pain. And what is the classical symptom? The classical symptom is that the patient will tell you that, doctor, whenever I try to stand erect, the pain, the lower back pain increases. Rather, whenever such patients come to us in the clinic with a history of back pain, whenever there is a patient who comes to us in our clinic, in our GP clinic with a history of back pain, with a chief complaint of back pain, the first question which we ask is, tell us about the exaggerating uh, features or exaggerating factors for your back pain. The patient will, at the time, the patient will tell you, doctor, the back pain increases by standing erect or whenever I move downhill. Okay, the back pain increases. Then the other question which we ask is, tell us about what are the factors which relieves your pain, which relieves your back pain. Okay, which relieves your back pain. And whenever you ask this very question to the patient, okay, and he will tell you, doctor, you know, whenever I move uphill, the pain in the pain decreases. Okay, the pain decreases. Or whenever I do flexion of the back, okay, whenever I do flexion of back, the pain decreases. Okay, or in your examination they will tell you this pain is getting relieved while the patient is moving a cart. Okay, in a mall he is moving a cart, and this decreases the pain. This is what you will see in a patient who is having lumbar or rather we will say spinal canal stenosis. Okay, spinal canal stenosis. Remember that. Then they will ask you about the other things, the associated features or associated symptoms. The associated symptoms in such patients would be none other than your pain, which we have already discussed. Number second is your numbness. Okay, numbness will depend on the level of stenosis. Okay, more importantly, you will see this spinal stenosis at the level of L3, L4, L5, or you will see L5, S1, and S2. More importantly, you will see the spinal stenosis over here, L5, S1, and S2. Okay, this nerve involvement would be more importantly at the level of L5, S1, and S2. And if you remember the nerve roots for the uh, knee reflex is L3 and L4. Okay, we say L3, L4, L1, L2 is none other than your testicles move. That's your cremasteric reflex. L3, L4 is kick the door, right? Kick the door. And that is none other than your knee reflex. Okay, knee reflex. And then we have S1 and S2. Okay, S1 and S2. S1 and S2 is your none other than your ankle reflex. Okay, ankle reflex, which is basically buckle my shoe. Okay, S1, S2, buckle my shoe. And whenever I say S1 and S2, buckle my shoe, that represents the no roots for the ankle reflex. And when I said that those patients who have spinal canal stenosis, they are more importantly be this spinal canal stenosis more importantly to be present at the level of L5, S1, and S2. Therefore, such patients would have this decreased ankle reflex. That means dorsiflexion, dorsiflexion in such patients would be decreased, isn't it? Dorsiflexion in such patients would be decreased. That's what you need to know. Also remember that if whenever I talk about L5 involvement, also what is the role of L5? It is responsible for the sensations, right? The peripheral sensations in uh, near the foot and all. Therefore, L5, the area which is supplied by the L5 nerve root, the sensations would decrease. Okay, decreased. And therefore, such patients who have spinal canal stenosis, they may come up with these features also, right? They will give an idea that the dorsiflexion is not the power of dorsiflexion is not over there, or on the neurological examination there is absent reflex, absent ankle reflex, or decreased dorsiflexion. There's L5 sensation, that the area which is supplied by the L5 nerve root, the sensation is decreased, or there is no great toe sensation, no great toe sensation, or I would say that no great toe extension rather. What does that mean? No great toe extension means, right, if this is the great toe, that means it's not moving up, it's not doing the dorsiflexion, it's not getting extended. And that's more importantly seen in those patients who have decreased ankle reflex. Therefore, such patients should be classified, or those patients should be signified as a case of none other than the spinal canal stenosis. This is what you need to know. Now, whenever you suspect, whenever you suspect these things in a patient, sometimes there would be numbness, right? There will be even tingling sensation will be over there, right? Tingling sensation would be over there. So whenever you suspect that the patients have spinal canal stenosis, okay, then if they ask you about next investigation. Now, what should be the next investigation in these patients? It will be none other than MRI. Please remember this. If you suspect spinal canal stenosis, you need to go for the MRI. And how do you suspect? The patient once comes to you in your clinic with lower back pain, he will complain of lower back pain, and the first question which you will ask is, what are the exaggerating factors for this lower back pain? Does anything increases the pain, increase the lower back pain? He will tell you, yes, doctor. Whenever I try to go downhill, this pain, what? This pain increases. Or whenever I try to stand erect, this pain increases. And now, the second question would be, what are the factors which relieves your pain? He would tell you, doctor, whenever I try to flex my back, the pain decreases. Or whenever I try to move uphill, okay, please remember this, move uphill, okay, the pain decreases. The pain decrease. Or whenever I move a cart in the in a mall or somewhere else, the pain decreases. Because this flexion, every particular point is it is related with the flexion of the back. Whenever a patient does the flexion, the gap between the spinal canal increases, the spinal canal increases, and therefore the impingement decreases, therefore the pain decreases. And what is the investigation? MRI. What is the investigation? MRI. So patients would come up with such features including there would be numbness, dorsiflexion weakness, there would be L5 area sensation would be decreased, and what is the other, what is the next investigation? Of course, you will go for the MRI, because you have to see the nerve root, you have to see the spinal cord, or you can think about the PIVD, prolapse intervertebral disc herniation, right? That is one of the differentials whenever there's a patient who comes up with the back pain. So, or there could be a tumor, or there could be a nerve root compression due to any other reason. So, therefore, you have to go for what? MRI. Okay. Then, once we are done with this, then they will ask you. Then they will ask you about the management part. Then they will ask you about the management part. And what is the management part? Please remember that. Remember one thing, that the management part is what they will ask you in the examination. This is the MCQ of 2025, probably in April and March also. And what you need to know is that you have to go for conservative. You have to go for conservative. You have to go for conservative treatment. Okay? You have to go for the conservative treatment initially. The concept is that, the basic concept is that if the patient is not having any, right, any what we called as, there is no neuro deficit, okay, there is no neuro deficit, so therefore initially we'll go for the conservative treatment, where we'll just give the NSI, right, NSAIDs, plus we will go ask the patient to go for the physiotherapy. Please remember that pain should be addressed, plus you have to go for the physiotherapy. Now, if the patient is having a severe neurodeficit, or they are asking about the definitive management, at that time you won't think about anything but the laminectomy. Okay, you'll go for the laminectomy. That's it. Can you see it here? Can you see this ligamentum flavum? Can you see it over here? Sometimes this ligamentum flavum can be seen on the MRI. They will tell you that we went for the MRI and the ligamentum flavum is hypertrophied, or there is hypertrophy of the ligamentum flavum. At the time, you don't have to think about anything else but the spinal canal stenosis, because in it has been seen that there is a relation of ligamentum flavum hypertrophy and then the spinal canal stenosis. Okay, I hope this is clear. So this is all about your spinal canal stenosis. Now there's a good differential. There is a good differential of spinal canal stenosis. There's a good differential of spinal canal stenosis, and that is none other than your okay. Let me write it over here. That is none other than your peripheral vascular claudication. Okay, peripheral vascular claudication. So let me make it like this. So yeah, we're good to go, and just make it something fancy. Okay, now peripheral vascular claudication. What are the things which will differentiate the spinal canal stenosis from the peripheral vascular claudication? Remember that spinal canal stenosis is due to the nerve, but the peripheral vascular claudication is due to the involvement of the vessels, right? Now, what will be the sign symptoms? Sign symptoms would be that the patient will tell you that doctor, there's tightening and cramping pain over my legs. Okay, tightening and cramping pain. And then you will ask the patient, is there any factor which is relieving or exaggerating the pain? right? Or you have to differentiate in your mind of spinal canal stenosis, then what would be the next question which you'll ask? You will ask the patient, is there any improvement with the flexion? Is there any improvement? Is there any improvement with the flexion of back? You will ask the patient, is there any improvement, right? Is there any improvement with flexion of back? Once you will ask this, then of course in these patients the answer would be no. Why? Because the reason is it is not the nerve which is involved in spinal canal, rather it is the vessel which can be peripheral, which is involved where the patient is having disease, right? So there would be no improvement of the back pain or the peripheral pain with the flexion of the back. But remember one thing, the patient will tell you, then you will ask, then what is the factor with which the pain is relieved? And he will tell you, doctor, whenever I lie flat, the pain decreases. Okay, he will tell you that, doctor, whenever I lie flat, the pain decreases. While in uh, lumbar canal stenosis or the spinal canal stenosis, the pain persisted while lying flat, right? There was no improvement, or the only improvement was done, was there when the patient was flexing the back, when the patient was moving the cot, or when the patient was moving uphill. But over here, the patient's pain gets, improves when the patient lies flat. And another important point is that the pain in the peripheral vascular claudication, it increases while going uphill, okay, even with the downhill, and even with extension of back, that is lying, standing erect. So there's only one particular point which is decreasing the pain, that is while lying flat. While lying flat, this is what you have to remember in case the patient is having spinal canal stenosis or the patient is having peripheral vascular claudication. Done. So once we are done with this, once we are done with, knowing the difference between the peripheral vascular claudication and the spinal canal stenosis, this is the only thing which you have to remember in case of your examination. This is something which will definitely be asked in your exam. Then, uh, what else? Now we will discuss about some important points to remember in case of back pain. Okay, in case of back pain, this is more related with the MCQ, but yeah, you can also use it while, uh, you know, uh, doing your clinical examination, or you are going to go for the AMC clinical examination, even for the pesky examination. If they mention, okay, if they mention about that the patient is having back pain, and this back pain, there is point tenderness, there is point tenderness, okay, there is point tenderness, the next step would be you have to go for the X-ray. Please remember that it is point tenderness and nothing else. Point tenderness, okay, point tenderness. And what could be the differentials? Maybe there is a vertebral compression fracture, okay, or there is a systemic the patient is having using the systemic corticosteroids and now complaining of point lower back pain with there is point tenderness. Remember that this is not the spasm, but we are talking about the pointing tenderness. Okay, you just poke with the help of finger, okay, on the back of the patient, and there is a pointing tenderness, or there is a history of trauma, or there is a risk factor for osteoporosis. In these patients, if if there is pointing tenderness, okay, then you have to go for the next step, that is none other than your x-ray. Now, what is the other point? Lumbar, if they talk about the lumbar tenderness, not the pointing tenderness, but rather the lumbar tenderness with no neurological deficit. Make sure that in the stem or the patient is not having any neuros deficit. Now, what is the next step? What is the next step? You ask the patient to go for conservative treatment or conservative management, and that is none other than you will advise the patient to go for or continue your work, continue activity and physiotherapy. This is what you need to remember. But remember that if this patient who is having the spinal stenosis and sorry, the lumbar tenderness, but the patient is also having neuro deficit, like for example, the motor deficit is over there. Okay. At the time, what you will do is that it is a red flag, so therefore you have to go for the MRI. You have to go for the MRI. Now, third point, or the third one is that if there is a history of cancer, there is a patient who is having history of cancer and now complaining of back and now complaining of back pain. What you will do, the next step would be none other than your X-ray. Okay, this is beautifully used in your AMC examination. Plus, you will see the C-reactive proteins or ESR. Okay, if C-reactive protein or ESR is increased, okay, and the neurologic, and you went for the X-ray and it is suggesting that the patient is it is suggesting it suggests that the patient is having cancer. So therefore you go for the management of metastatic cancer, right? Like the breast carcinoma or the prostate carcinoma, whatever it is. But if the X-ray is normal, if X-ray is normal, but the patient's C-reactive protein uh, or the ESR, it is raised, what is the next step you will do is none other than your MRI. Why? Why do you go for that? Yes, the patient can have osteomyelitis even. Okay, in such patients, there's a risk for the osteomyelitis. And then there is last one which I want to discuss over here. That is none other than your that patient is an IV drug abuser. IV drug abuser. They will give you that the patient is an IV drug abuser and he is taking drugs. Okay, he is a frequent user of IV drugs. Now he's complaining of back pain. Okay, if there is an IV drug abuse of the patient who is coming to us with a back pain with a history of IV drug use, uh, for the drugs he's taking marijuana or whatever it is, okay, or the cocaine. So the initial if they write what is the initial radiological investigation will do is X-ray. Because such patients who are having IV drug who are IV drug abusers, plus there is back pain, you have to suspect that the patient can have osteomyelitis. And the X-ray is the initial investigation, radiological investigation followed by MRI, and it is the best step, or the most appropriate step. Drug abusers should have raised, these drug abusers, these patients should have raised temperature. That is, the patient would come up to us with back pain, with fever, or there is a C-reactive protein which is increased, or there is ESR which is raised. That's very, very important. Remember one point, that if there is a patient who is having point tenderness with fever, okay, point tenderness with fever, please remember this. This is a classical presentation of none other than, that is what we call it, this the inflammation of the vertebral disc, that is discitis. Okay, I'm just giving you the 6 7 stars for this very point, because this is very rarely mentioned in any lecture. So that's what you need to remember in a patient who is complaining of lower back pain. Okay, and now let's talk about none other than your what we call as cauda equina syndrome. Rather, just let's erase this, okay? Because I know it should be something cauda equina syndrome. Okay, cauda equina syndrome, again, important topic for your exam, and I want you to remember this, because whenever you go for the exam, and whether it is AMC or anything else, definitely this cauda equina syndrome is important as a GP also, as for your examination, whether it is AMC 1 or 2, is very important for the exam. Now, let's make it very simple. They will, trick you in between two things. Number one is conus medullaris, and other one is cauda equina syndrome. Okay, cauda equina and the conus medullaris. Now, if you remember from the basics, whenever we talk about a spinal cord, right? Spinal cord, at the end, it tapers down, right? It tapers down. And this part, if you can see here, this last point, this last part, triangular part of the spinal cord, it what is called as conus medullaris. Okay, conus medullaris. That's what you need to remember. That is what you need to remember. And from this conus medullaris, what are the nerves which come out from this? Okay, it is your S1, from S1 to coccyx. Okay, it is C0. That is S1, S2, S3, and S4. Okay, and then C0. This is the conus medullaris. And this one, the other part which is coming from L1, then L2, L3, L4, and then L5. This is what we call as cauda equina. Okay, cauda equina, because it basically looks like a horse tail. Okay, horse tail. So cauda equina Cauda equina is basically a lesion which is involving whole part starting from the lumbar area to the conus medullaris part also. So if there is a patient who is having conus cauda equina syndrome, that means he is talking about the involvement of the spinal cord from L1 to C0, right? C0. And whenever they talk about the conus medullaris, it is the involvement from S1 to C0, right? Now hopefully this is very easy for you to differentiate between the conus medullaris syndrome and the cauda equina syndrome. Cauda equina syndrome would involve the lumbar nerves also, lumbar nerve roots also, including the sacral and coccyx. And but in the conus medullaris there is only a small portion which is involved, and that is the sacral part. That is the sacral part. Now let's go back to our uh, basic uh, knowledge, right? We said L1 and L2, that is testicles move, and that is cremasteric reflex, right? Cremasteric reflex. Now imagine in these patients there is involvement from L1 to C0, so therefore L1 and L2 will be gone, therefore cremasteric reflex will be absent. Okay, how to elicit this cremasteric reflex? You just tap, or you just slap or tap the medial aspect of the upper thigh. There is the testicles. Okay, the testicles in the patient, they move up. That is what we called as cremasteric reflex, and it is by the nerve root of L1 and L2. Cauda equina syndrome, this is hampered, therefore no cremasteric reflex. Now then we talked about L3, L4 and L5. L3 and L4 is responsible for the kick the door. L3, L4, kick the door, that is knee reflex would be absent, right? With that, the patients uh, S1 and S2, that is buckle my shoe, ankle reflex would be absent, isn't it? Ankle reflex would be gone. Even with that, the patient will have saddle because S1 and S2, right? The patient will have saddle anesthesia, that is, the buttocks won't have any sensation, no sensation. With that, the patient's inferior rectal nerve, which comes from the sacral plexus, there is involvement of this, which eventually results in the involvement of the bladder also, or yes, bladder also. So inferior rectal nerve is involved, so bladder is gone, therefore there is bladder gone, bowel gone, therefore there is incontinence or urinary retention. These are the features which are seen in a patient who is having cauda syndrome. But those patients who have just conus medullaris, what would be the same symptom? It is just the involvement from S1 and S2. We talk about S1, S2, it is buckle my shoe, so only the ankle reflex would be gone. But what about the knee reflex? That is what he will ask you. Knee reflex is present, right? Knee reflex is present because in conus medullaris, the L3 and L4 would be okay. Now, sometimes there is hyperreflexia, okay, when there is involvement of S2 and to S4, right? This is S2 and S4 is what gives up the pudendal nerve, and you know better than me that pudendal nerve is what supplies the anal sphincter. Okay, what supplies the urethral sphincter? And what supplies the bulbospongiosus, tissue of the penis? And if this is hampered now, what will happen? There is stool incontinence, there is urinary incontinence, and there is impotence due to the involvement of the bulbospongiosus. Now, S2S4 is also giving a rise to pelvic splanchnic nerve. Okay, and when there is involvement of this also, it results because this pelvic splanchnic nerve is involved. It is supplying the detrusor muscle. Therefore, the function of the bladder is also hampered. Now, what is the treatment? How do you treat such patients? You go for IV steroids. That is none other than your dexamethasone. That is Dexona. Okay, that's the dexamethasone. You would emergently go for urgently go for MRI and CT myelogram. Okay, if MRI is contraindicated, you can go for the CT myelogram. And the last one is surgery, because it is just it is emergency. Okay, it is emergency. Now this cardiac venous syndrome could be due to the trauma, it could be due to the infection, or it can be due to the abscess, or it could be due to the abscess. Done. So once we are done with this, let's talk about, I just want to mention about the red flags. Okay, let's talk about the red flags of the back pain. Okay, red flags of the back pain. Red flags of the back pain. Now remember that if there is a patient who is having back pain, and this back pain is, and the age of the patient is more than 50 years, then is a red flag itself. And or we can say that if the patient is of less than 20 years old and he's complaining of the back pain, it is a red flag, because such patients have ankylosing spondylitis, morning stiffness and all. There is sacroiliitis, and that's what you have to remember. Now, again, important, those who have less, more, those whose age is the people who with an age of more than 50 years, think about osteoporosis. If there is a back pain, another red flag, if there is a back pain which is persistent for more than 1 month, if there is a back pain which is associated with cough or breast mass. So these points are indicating maybe it's related with lung, maybe it's related with the breast, metastasis, carcinoma, right? Or the patient is on the anticoagulation, and because this can result in the spinal canal, this can result in the subdural hematoma, resulting in the accumulation of the blood in the spinal canal also, right? In the spinal cord also, because there is an extension of the meninges to the spinal cord. Therefore, you have to Make sure that the patient is not on the anticoagulants or the patient is taking corticosteroids, because there's high chances that the patient may go into this osteomyelitis and all, because corticosteroids immunosuppressants resulting in osteomyelitis or even osteoporosis also. Fever. If the patient is having fever of more than 37.8 degrees Celsius, rule out the osteomyelitis. Those who have back pain with the fever of more than 37. Alcohol. If the patient is on the alcohol with the back pain, or IV drug abuser with the back pain, initially, as I said, those who are IV drug abusers with back pain, you have to go for the X-ray followed by the MRI, which is the best investigation. If there is a history of severe trauma, or there is a history of weight loss with back pain, or there is directly a history of cancer, right? Or they will sometimes tell you that there is a day and night persistent back pain. This is what is basically a red flag for the back pain. This is what you need to remember for the back pain part. And I don't think that there would be any other question which is asked in your exam. So this is more than enough for the back pain. Let's discuss about now uh, now we will be discussing about the carotid artery stenosis, another very important topic for your exam. So yeah, by the definition, see, by the definition or by the wording, by the term, you can easily deduce that the patient is having what? The patient is having carotid artery stenosis, right? So there is the narrowing of the carotid artery, and we know that uh, the internal carotid artery is what basically supplies our brain, right? Brain. And that's again a very, very important point over here. So if there is any plaque over uh, or in this internal carotid artery or in the common carotid artery, this will result in decreased blood supply to the brain, right? To the brain. And this is what we call as ischemic stroke, right? This is what we call as ischemic stroke, right? And remember that the sign symptoms of this stroke, right? A simple stroke. If these sign symptoms of this stroke they resolve in less than 24 hour, that is what we called as transient ischemic attack. That means the patient had some the patient was having like amaurosis fugosis, or the patient had some impairment, upper or the lower limb impairment, with the drooping of eyelid, with facial impairment, or the patient had some the blindness and temporary or the transient blindness. That is what we called as amaurosis fugosis. And after 24 hours all the symptoms got resolved. That is what we called as transient ischemic attack. But if this persists, the ischemic stroke the patient had now, then what is ischemic stroke? If the symptoms of stroke, okay, if the symptoms of stroke continue even after 24-hour, of course we will discuss this. So as you can see over here, so transient ischemic attack, the clinical criteria is that there is an ischemic neurological symptom that resolve completely within 24 hours after onset. And there is a radiological criteria also, which will show the presence of ischemic neurological symptoms without evidence of infarction, number one, on central nervous system imaging. That's very important. And the Other one is stroke clinical criteria, where the ischemic neurological symptoms persists for more than 24 hours, and the neurological criteria may show the presence of infarction on the CNS imaging. That is mostly done with the CT scan. Okay, mostly done with the CT scan. Rather, we go for the NCCT in such patients. Now, what are the symptoms? There is a drooping of one side of the face. There's a slurred speech or trouble forming words and communication with others. There is these all the episodes are sudden. These all the symptoms are very sudden. Okay. Then the patient may complain of loss of vision in one eye with experience of a dark shade coming down over your field of vision, and that is what we called as amaurosis fugosis if this is transient. Okay, then losing feeling on one side of your body, that is a paresthesia, or losing muscle strength and having weakness on one side of your body, that is what we call as paralysis. Okay, it could be hemiplegia, sometimes it could be paraplegia also. Now, now the important point in this patient is none other than the diagnosis and the management part. Diagnosis and management part is again very important for these patients. And before that, we need to see that asymptomatic carotid artery stenosis. Asymptomatic carotid artery stenosis is the presence of hemodynamically significant carotid artery stenosis that has not caused an episode of neurological ischemia. Should remember that the carotid artery stenosis, sometimes this carotid artery stenosis is present in elderly patient which is not diagnosed because there should be the significant stenosis. There should be significant stenosis in order to cause what? In order to cause symptoms. Or without this, there is a mild stenosis, right? There is a small stenosis, but the plaque which was resulting the stenosis, if we go back, this plaque which was resulting in stenosis, this dislodges. Okay, this dislodges and goes into the brain, and resulting in ischemic attack. Okay. Similarly, if this carotid artery stenosis is over there in an elderly patient or in a patient and you found it incidentally, okay, so that means the patient was asymptomatic, okay, or you went for the physical examination or something like that and you heard a bruit, okay, there was a bruit on the or near the carotid artery, and therefore, you are now pretty sure there is a plaque which is present in the carotid artery. Therefore, you go for the ultrasonography, Doppler ultrasonography, where you will see that the patient's having what plaque in the carotid artery. Eventually, the patient is having stenosis, and now with the help of ultrasonography, you will measure the stenosis. Okay, the percentage or the amount of stenosis. So that means if there is an asymptomatic, whenever there's a patient who in which you incidentally found out that the patient is having asymptomatic carotid artery stenosis, so they are hemodynamically stable, right? So asymptomatic carotid artery stenosis is the presence of hemodynamically significant carotid artery stenosis that has not caused an episode of neurological ischemia in preceding 6 months. In most cases, asymptomatic disease is detected following auscultation of the carotid bruit as an incidental finding on axial imaging or after the carotid duplex ultrasonography evaluating symptomatic disease on the contralateral side. Okay, so there's a patient who had one side, at one side, like for example, this is the carotid artery and this is also the carotid artery. At one side the patient had some symptoms, and now what happened is that you of course you went for the Doppler ultrasonography for this very carotid artery which was showing the symptoms, but you have to go for the other side also to check the control, rather we say that the other side stenosis also. Therefore, both the carotid arteries should be evaluated or checked out if the patient has symptoms at one side or bruit or at the one side. right? So how do you diagnose? You go for the carotid duplex ultrasonography, which is the first line investigation for the carotid artery disease, as it is an inexpensive, non-invasive modality that has been shown to be accurate in estimating the degree of stenosis when compared with angiographic measurement. So therefore, any patient who comes up with this transient ischemic attack, or a patient comes up with the stroke, you have to go for what? You have to go for the carotid duplex ultrasonography rather than the angiographic measurement and all. And it should ideally be conducted. It should ideally be conducted. It should ideally be conducted at an accredited vascular laboratory with the results classified according to Australasian Society for Ultrasound in Medicine criteria. CT scan angiography, CT angiography can be a secondary imaging modality that is particularly useful for surgical plans. So, if there is a patient who is having carotid artery stenosis, okay, in short, if there is a patient who is having carotid artery stenosis, suspected case of carotid artery stenosis, like the patient had those features which we have already discussed, you will go for ultrasonography, carotid artery ultrasonography. And the second line, if uh, they don't give you the option of the carotid artery ultrasonography, at the time you have to go for the CT NGO. Okay, this is the secondary imaging modality. This is the secondary imaging modality. Now, once we are done with the symptoms, once we are done with the definition, then we have to discuss about the management part. Okay, we'll discuss about the management part, where there is, like, for example, there's a patient with a suspected case of carotid stenosis. You go for the carotid duplex ultrasonography. Stenosis detected. At the time, you have to measure the degree of stenosis. And with that, initially you'll start the patient until unless the patient is having any like carotid artery dissection. Other than that, every patient who is having carotid artery stenosis, if they ask you about the initial management, whatsoever the case scenario is, if they ask about the initial management, you have to go for the lifestyle modification. You have to go for the lipid lowering therapy. You have to go for the antiplatelet therapy. More importantly, the usage of aspirin is always over there. But let me remind you with one particular point is that if the patient is having even if there is a patient who is comes to go for the surgery and arterectomy, still the patient and if they ask you about the initial part, or the initial management, he should go for the aspirin and all. After that, the patient will go for the surgery. So initial antiplatelet therapy followed by the surgery in those who are required to go for the surgery. Now, who are required to go for the surgery is those patients who have stenosis of less than 50. They don't need any kind of revascularization. You'll just talk about the lifestyle modification, lipid lowering therapy, or you can go for the antiplatelet therapy also. Now, those patients who have stenosis of more than 50 and they are asymptomatic, they are what? Asymptomatic. Now, if they are asymptomatic, then you will measure, right? You will still, you have to, of course, if it's more than 50, if it's more than 50 and the patient is asymptomatic and the stenosis falls in the moderate criteria, that is 50 to 69, you won't go for the revascularization. Rather, I will tell you one thing, that this guideline is basically from the AHA, that's American Heart Association. If we talk about the RACGP, or the Australian Heart Association, they say that if there is any patient who is asymptomatic, I will just rectify this, and let me do it over here. If the patient is asymptomatic, right? If the patient is asymptomatic and the stenosis and the stenosis is less than 80%, no revascularization is required. And if stenosis is more or equal to 80%, go for revascularization. This is what you will remember. Forget about this part. Okay. Then symptomatic. Those who are asymptomatic and the stenosis is more than 50. Okay, more than 50. Remember that if it is 50 to 69, you will consider elective end arterectomy. You will consider the revascularization. Okay, that would be elective, and initial treatment would be antiplatelet therapy. Those who have severe stenosis and they are symptomatic, that means the patient had features of stroke or transient ischemic attack, and it is 70 to 79, you will go for the revascularization immediately. Okay, immediately. And carotid and arterectomy is the first line. Carotid stenting can be also done, or carotid artery bypass graft can be also used. Now, where did I found out that the criteria for the asymptomatic is different? It is on your RACGP guideline. You can see here in patients who are asymptomatic, a reasonable approach for general practice point of view is to refer asymptomatic patient with ICA of more than 80% for non-urgent vascular surgical review for consideration of surgery. So that means those patients who have less than more than as you can see here more than 80, they are commenced to go for the surgery. They are required to go for the surgery. But those who have less than 80% internal carotid artery stenosis and are asymptomatic, referral is usually not required. Okay, referral is not usually required. So this is what they will ask in your examination. So that means you don't have to now. You will not never ever get confused about this very question. Now, key points of the carotid artery stenosis. Carotid artery stenosis. Uh, if you can see over here, the carotid artery stenosis is a major cause of acute ischemic stroke. The disease can be classified as asymptomatic or symptomatic on the basis of correlation of disease with a recent stroke or TIA. Patients presenting with acute neurological ischemia or amaurosis fugax, which may be a manifestation of symptomatic carotid artery stenosis, should be promptly referred to an emergency department, or discussed directly with a vascular surgical service. Patient with symptomatic carotid artery stenosis, okay, should be commenced on antiplatelet therapy and considered for the surgery as already discussed. Patients with asymptomatic carotid artery stenosis should be commenced on the BMT with referral to vascular surgical service when the degree of stenosis exceeds more than 80. If the degree of stenosis is less than 80, yearly surveillance with the carotid Doppler ultrasonography is appropriate rather than going to go for the BMT and all. Carotid artery and carotid and arterectomy is the gold standard. Okay, it is the gold standard for the surgical management of the symptomatic carotid artery stenosis and should ideally be carried out within 2 weeks. Okay, from the initial event. For those 2 weeks, what you will give? Antiplatelet therapy, and it aims to reduce the recurrent stroke risk with no impact on outcome of the initial stroke. Then that's that's your topic of carotid artery stenosis. Hopefully this is all clear in your mind. If you have to remember one thing, that is the management part and none other than your um, investigations. Okay, and hopefully this is all clear now. Now let's talk about another important point in the discussion. We will discuss about the carotid artery dissection now. Okay. Now we'll be discussing about the carotid artery dissection. So what is carotid artery dissection? What is that? It is basically a tear in tunica intima. It is just like your aortic dissection, right? When there was tear in the tunica intima and the blood was entering into the layer of vessel walls, mostly in the tunica media. right? It is just like same in case of carotid artery dissection. Eventually, there is formation of mural hematoma and dilation of internal carotid artery, and eventually there is compression of the lumen, and mostly the source of emboli is the cause of the stroke in the carotid dissection. As you can see over here in the radiological uh, imaging, we can see over here that the patient is having carotid artery dissection indicated by the arrows over here, as you can see over here. Done. So this is what we call as carotid artery dissection. And these patients who have carotid artery dissection, uh, the patient will come up with the sudden, okay, the patient will come up with sudden onset of thunderclap headache. Okay, I guess you have seen this thunder, or you have heard about this thunderclap headache in one another disease, in any other disease also, right? And basically, so therefore the differential diagnosis would be subarachnoid hemorrhage, okay, and even it can be in the pituitary apoplexy, and it can be even the pheochromocytoma. Now, those patients who have carotid artery dissection, we have already discussed what happens in this, and there is the patient will have come up with thunderclap headache, and then there is a triad basically. What is the triad? The patient will complain of pain. There will be pain on one side of there will be pain on one side of headache, one side of head, sorry, or face and neck. So neck is very important over here. The patient will have the carotid artery dissection. Of course, it's near the present or near the neck. So therefore, the patient will come up with the pain, and that would be near the neck region also, right? Half of the patients who have this carotid artery dissection, they come up with the neck pain, and this face and the face pain. It would be just like the cluster headache. What is the characteristic of the characteristic pain or the headache in the cluster headache? A retroorbital pain, right? Retroorbital, or we say orbital pain, or there could be ipsilateral facial pain. Ipsilateral facial pain. And this headache, this headache is mostly just like the thunderclap headache. Thunderclap headache. Now, what is the second point? Second point is that the patient would come up with the Horner syndrome. If you remember, I have discussed this Horner syndrome in one of my lectures, and I have particularly talked about those patients by Horner syndrome with the neck pain is a case of neck dissection, carotid artery dissection until proven otherwise. Those patients who have Horner syndrome with the chest pain or chest lesion on HS X-ray, that is a case of Pankos tumor, right? So anywhere you suspect that the patient is having Horner syndrome, the first thing you need to rule out is the your carotid artery dissection. Okay, so Horner syndrome is also present. So there will be meiosis, anhidrosis, and shrunken eyes. The reason being is that the uh, sympathetic plexus, okay, the sympathetic plexus basically goes into the brain along with this carotid artery. When there is dissection of this, there's involvement of the sympathetic plexus also, and when there is sympathetic plexus is involved, it results in the Horner syndrome, meiosis, and hydrosis, shrunken eyes. That's what you need to remember about the Horner syndrome. And the third point in the triad is none other than the patient will have cerebral or retinal ischemia. Patient will have cerebral or retinal ischemia. Okay, it would be from minutes to days, but it will be reversible. 90% of the patients who have carotid artery dissection, they go with the transient ischemic attack. Okay, transient ischemic attack. Other than that, sometimes there is involved of three nerves, which would be cranial nerve. Three would be involved, and sometimes cranial nerve 12 is also involved. So these two nerves, cranial nerves, are involved in these patients. Okay, hope this is clear. Now, if they talk about the diagnosis, now what is the how do you diagnose these patients? It's very simple. Initial as initial, we go for the ultrasonography. That's very, very important point. Any patient who comes up with the Horner syndrome like symptoms with the neck dissection, if they talk about the initial, okay, initial ultrasonography, but if they don't talk about the, if they don't ask about the initial and they ask for the most appropriate or the best or the definitive, then you have to go for the CT NGO. CT NGO. Remember that if you go for, if you go for the guidelines in the Medscape, they will say that you have to go for the MR, okay, MR angiography. But according to the Australian guidelines, therapeutic guidelines, they say CT NGO is as better as, they write it as, it is as better as, it is as better as MR NGO. So this is what you have to remember, and I, I request you, please just write it down that the diagnosis is mostly done with the help of the CT NGO in case the patient is having what? Carotid artery dissection. Now, uh, what is other, uh, other dissection? If we talk about the circle of Willis, okay, if we talk about the circle of Willis, we talk about the internal carotid artery. What is the other artery about which we always discuss? That is vertebral artery, right? Vertebral artery. And when we talk about the vertebral artery, if there is a dissection of, if there is dissection of vertebral artery, if there is dissection of vertebral artery, that is what we called as vertebral artery dissection, isn't it? Vertebral artery dissection. And these patients who have vertebral artery dissection, those patients who have vertebral artery dissection, they come to us with a triad of, with a triad of, or we say with a characteristic feature of hemiplegia, okay, plus the patient will have ophthalmoplegia. And any patient who comes up with the headache plus hemiplegia and ophthalmoplegia, always suspect that the patient is having none other than your vertebral artery dissection, and this is what we called as Wallenberg syndrome. Okay, Wallenberg syndrome. You have to remember this, please. Wallenberg syndrome. Once you are done with the Wallenberg syndrome, and then they will talk about the diagnostic part. So for that reason, for these patients who have such uh, features like hemiplegia, ophthalmoplegia with the headache, you suspect that the patient is having Wallenberg syndrome, that is lateral medullary syndrome rather. Then diagnosis is of course done by the CT NGO or MR NGO. I hope this is clear. Okay, I hope this is clear. Now we will discuss about the cavernous sinus thrombosis. As you can see, this is a patient of carotid artery, cavernous sinus thrombosis. We have already discussed about the carotid artery dissection. We talked about the vertebral artery dissection. I will discuss about the cavernous sinus thrombosis. As you can see, sorry, as you can see here, what has happened to this very patient? What has happened to this very patient? Let's see. This is basically a 34-year-old woman with severe bilateral proptosis. As you can see, the eyes are bulged outside, right? And chemosis, right? As you can see here, this reddish appearance, this is what we call as chemosis due to extensive cavernous sinus thrombosis confirmed on the MRI. We can even see the, such patients. Basically, this is a real case scenario, real patient, uh, and these guidelines are taken from beautiful LITFL of Australia. And you can see here, see what they write over there is that cavernous sinus thrombosis in the antibiotic era remains a vital diagnosis to make, as mortality and morbidity remains extremely high if missed. And cavernous sinus thrombosis is a devastating condition with mortality rate of 30%. Then they have written over there that you have to diagnose it with the help of MRI. If MRI is unavailable in urgent time frame, CT venography can be done. Remember that there will be one option. Uh, Here we don't go for this, we go for MRI, right? MRI. And if it's not present, we go for CT venography because it is the cavernous sinus thrombosis, right? If you can see here, if this is the cavernous sinus, right? This is the sigmoidal sinus, and there now there is this cavernous sinus at the lateral sides of this. And you can see here this part. Let me show you this part. This is what we call as cavernous sinus, right? And this cavernous sinus, we have internal carotid artery, right? We have internal carotid artery. We have oculomotor nerves on the lateral side of this, trochlear nerve, ophthalmic nerve, abducens nerve, and the maxillary nerve. So just imagine if the patient is having cavernous sinus thrombosis over here, it can result in the involvement of these all cranial nerves also. So with that, what will happen is that the patient will have come up with the headache, unilateral periorbital edema, sometimes bilateral if it is bilateral cavernous sinus thrombosis, photophobia, proptosis, paralysis of cranial nerves. The involvement of sixth nerve will result in the diplopia, right? Uh, and then cranial nerve 3 involvement, that is the oculomotor nerve. So therefore, the most commonly the two nerves which are involved are none other than the trochlear nerve, which is most commonly involved, resulting in the diplopia, and the other one is third nerve, that's oculomotor nerve, resulting in ptosis, mydriasis, and eye muscle weakness. Investigation used is MRI. If it's not available, you can go for the CT venography, and the treatment is broad spectrum antibiotics because most of the patients who have this cavernous sinus thrombosis, it is mostly due to the infection, and mostly it is due to the staphylococcus aureus. It is one of the complication, it's one of the complication of the uh, what we say is that a middle ear infection, right? If the patient is having middle ear infection, one of the complication uh, of acute otitis media, when it goes into the chronic serous otitis media, one of the complications later would be the cavernous sinus thrombosis. Cavernous sinus thrombosis, because if you remember emissary veins, if this is the skull, if this is the skull, okay, and this is the ear, and we have here the middle ear, the veins which connect the external and the internal uh, cranial cavity, those are called as emissary veins. Those are called as what? Emissary veins. They are just like this. And if there is any infection which is in the middle ear, this infection can travel. Okay, it can travel and go into the none other than your cavernous sinus, resulting in cavernous sinus thrombosis. Resulting in cavernous sinus thrombosis. This is what you have to remember in this cavernous sinus thrombosis. Other causes can be Streptococcus pneumoniae, pneumococcus, gram-negative bacilli, anaerobics, but anaerobes, and you should also remember that as you can see over here, the ophthalmic vein it enters into the cavernous sinus, facial vein, and this and that. But yeah, one important point which I want you to mention, which you fourth cranial nerve is the trochlear nerve, which is also involved, but the sixth cranial nerve, which is basically the abduced nerve, which is most commonly involved in a case of cavernous sinus thrombosis, resulting in diplopia and all. As you can see over here, the late complication of infection in uh, middle third of the face, if the patient is having infection in the middle third of the face, paranasal sinus, septic complications, or middle ear infection, okay, highlighted orbital cellulitis. We have discussed this in the ophthalmology. And if the patients have non-infective, what are the non-infective causes? Thrombophilic genetic causes like factor V Leiden mutation, prothrombin, antithrombin 3 protein C, or the protein S deficiency, severe dehydration, and trauma. And what are the organisms which can result in cavernous sinus thrombosis? Is Staphylococcus aureus and all. See, I didn't. Yeah, of course, we will discuss about. You have to discuss, or you have to know about the symptoms. That's the most important point in while discussing about the cavernous sinus thrombosis. Other than that, you should know that there will be involvement of the trochlear nerve. There will be involvement of the third nerve, that is oculomotor nerve. There will be involvement of the abduced nerve, that is the sixth nerve, resulting in diplopia. That's most commonly seen in these patients. There will be chemosis, there will be bilateral proptosis, and you have to remember then the investigation that is done by the MRI. If not available, you can go for the CT venography. Treatment is broad spectrum antibiotics. Okay, the other one is you can go for the heparin and followed by surgery if it's not treatable with other two. It's not if it's not getting treated with other two. Mostly the questions of the cavernous sinus thrombosis, you know, you will see such questions in what we call the as pregnancy. Any patient who is pregnant and comes up with such features, think about the cavernous sinus thrombosis. Okay, think about the cavernous sinus thrombosis. As you can see here, cavernous sinus thrombosis is a devastating condition with mortality rate up to 30%. Even with treatment of survivors, the majority will have permanent cure. That's very, very important case, right? So this is what you need to remember in a case of cavernous sinus thrombosis. Hopefully this is all clear in your mind now. And now, what else should we discuss? We will discuss about the subarachnoid hemorrhage. And yeah, let's discuss about the subarachnoid hemorrhage. Now we'll be discussing about the subarachnoid hemorrhage. As you can see, as you remember that from the very basics, that uh, if this, for example, if this is the brain, okay, if this is the brain is covered with the meninges, right? We have three different layers of the meninges. Number one is pia mater, then we have arachnoid matter, and then we have the dura mater, right? The dura mater is dural meninges is the layer of the meninges which is in attachment with the periosteal, that is the US periosteum, that is your skull bone, right? Then arachnoid matter is basically your middle part of the meninges, and the pia mater is what is connected with the brain, right? So this is just like this. Okay. Now what is then subarachnoid hemorrhage? Subarachnoid hemorrhage means that there is hemorrhage which is just below this arachnoid matter, right? Arachnoid matter, the accumulation of blood just below this arachnoid matter is what we call as subarachnoid hemorrhage, and the most common reason of this is berry aneurysm. If there is a patient who is having persistent headache, okay, persistent headache, the patient can have impending this berry aneurysm, which is just about to rupture. You always suspect in those cases where there is persistent headache, a thunderclap headache. So what is basically the triad? The triad in these patients would be those who have this berry aneurysm rupture resulting in the subarachnoid hemorrhage. There would be triad. And what would be the triad? The triad would be number one, the patient will have thunderclap headache. The patient will complain of headache, which will be so severe that the patient will directly tell you, "Doctor, I have never ever felt this kind of headache in my life. This is the worst headache of my life." And second one would be neck rigidity. As there is accumulation of blood um, in the subarachnoid region, the increased intracranial pressure will result in projectile vomiting. What's projectile vomiting? Projectile vomiting means without nausea, the patient will start what? Vomiting. There will be vomiting without nausea. That's what we call as projectile vomiting. Remember that. So neck rigidity, headache with the projectile vomiting is what we suspect that the patient is having subarachnoid hemorrhage. If I will just add one point over here, that is fever, everything will change, and this will be now the meningitis rather than the subarachnoid hemorrhage. You have to rule out the meningitis in these patients if there is fever also. Okay, if there is fever also, but yeah, we don't have fever in this patient, so therefore we don't have to worry about this because the patient will have these three classical features only. And if you can see here, if you go for the CT head, this is your CT head, and in the CT scan you can see here this blood accumulation. Okay, this is what we call that star of death appearance on the CT scan. This is a classical case of subarachnoid hemorrhage. And if we can see here, what are the different uh, sites where this aneurysm could be present? Most importantly, they are present near the anterior communicating artery, right? As you can see here, it can come up or along or near the region of middle cerebral artery also, or the posterior even at sometimes near the posterior communicating artery also. Okay. Now, uh, if we do in these patients, if you go for the CT scan, in these patients, you will see this classical appearance of the ECG, where the patient will have inverted deep T waves, as you can see here, right? These are inverted deep T waves. Any patient who have these inverted deep T waves, right? Plus, they are more, you know, prominent in the precordial leads, like in the V2, as you can see here, in the V4, right? These are the precordial leads. And of course, these patients will have prolonged QT intervals also. And if you are finding such characteristic features on the ECG in any patient, please suspect that the patient could have this subarachnoid hemorrhage. This is what we called as cerebral T waves on ECG. Cerebral T waves on ECG are characteristic, or they are very classical for the sub uh, arachnoid hemorrhage sometimes. But more importantly, you have to remember that if such ECG is found out, You have to rule out the subarachnoid hemorrhage, number one. Number two is you have to rule out subdural hematoma also. Subdural hematoma will also have cerebral T waves. That means cerebral T waves could be present in the subarachnoid hemorrhage, it could be present in the subdural hematoma. But if you have to choose one, go for the subdural hematoma rather than the subarachnoid hemorrhage if they will ask you that cerebral T waves are more importantly, more classically seen in which particular intracranial hemorrhage, that would be your subdural hematoma rather than the subarachnoid hemorrhage. Okay, now what is the management part? Okay, let me just cut it over here and let's discuss about the diagnosis. Of course, the diagnosis is done by the CT head, and remember that if it's negative, but the patient has symptoms. Okay, the patient has symptoms which are persisting, which are very persistent for more than 6 hours, and now you are very sure or you are suspecting that the patient is having subarachnoid hemorrhage because he is coming up with thunderclap, headache, neck rigidity, and history of projectile vomiting, but the CT scan is negative. What do you do next? Do you observe the patient or send the patient to home with just a Tylenol? Yeah, you don't go for, you don't discharge the patient, rather you go for the lumbar puncture. Okay, if there is a highly suspected case of subarachnoid hemorrhage, you go for the lumbar puncture, even if the CT head is negative. Of course, you have to make sure that the patient is not having any contraindication for the lumbar puncture, where you will see now what? Xanthochromia. There will be RBCs in the CBC. But remember that if it's negative and still you are thinking that the patient is having subarachnoid hemorrhage, at the end you will go for CT angio. And now tell me about the treatment part. Treatment part of the subarachnoid hemorrhage, it is nimodipine. Okay, you'll go for the nimodipine, which is basically a prophylaxis. And of course, then once the patient is having this subarachnoid hemorrhage, you will go for the operative management. That is, you will go for the rapier. Need to rapier this. Okay, as I discussed that the sometimes the patient can have the cerebral T waves. It is more importantly seen in the subdural hematoma, not the subarachnoid hemorrhage, where the patient will have deep T waves in the precordial leads with a prolonged QT interval. It is mostly seen in in the subdural hematoma, right? What are the classical features of the subdural hematoma or the classical history which are asked in the question is that the patient will be elderly and there's a recent history of fall in washroom or while farming or while walking in a park, and now after some days he is coming to you with confusion. Please rule out this subarachnoid hemorrhage. What you will do is that you will go for what? CT scan. And in the CT scan, you will see this characteristic uh, CT head, and that would be this bleeding would be over there, which has crossed the sutures, just like this. Okay, just like this. And this is what they will ask you in the subdural hematoma. In addition to this, if they will give you that the patient is on anticoagulants and now complaining of headache or there is confusion, make sure that the patient is having what? You have ruled out what? Subdural hematoma. Okay, make sure you have ruled out the subdural hematoma. So once we are done with the subarachnoid hemorrhage, we are done with the subdural hematomas, epidural hematoma, and we have discussed the subdural hematoma in detail uh, in emergency medicine also. So yeah, for this very reason, I just wanted to make sure that this cerebral T waves are very, um, it is very clear in your mind that it is more common with the subdural hematoma, not the subarachnoid hemorrhage. Yeah, subarachnoid hemorrhage. In subarachnoid hemorrhage, we can also see this, but subdural hematoma, classical. Okay. Now, what else? What else do I need to mention about this? Is nothing. Okay. Now we will discuss about none other than your headache. We'll talk about now the migraine and cluster headache.